You've been taking the same little pill every morning for years. Your doctor started it back when your numbers were creeping up, and it worked. The cuff reads fine now. Your doctor nods, renews the prescription, and you move on with your day. But here's the question nobody in that exam room is asking. What if the pill that's keeping your blood pressure number acceptable is quietly working against you everywhere else? If you're more tired than you used to be? If the weight has started collecting around your middle no matter what you eat? If stairs leave you winded in a way they didn't 5 years ago? There's a real chance that pill is part of the story. And your blood pressure reading will look perfectly fine the entire time, which is exactly why nobody connects the dots. The pill is almost certainly a beta blocker. For 50 years, doctors have reached for this class of drug as a default for high blood pressure, and for one very specific kind of patient, it remains genuinely life-saving. But for the ordinary senior with plain high blood pressure and nothing else going on, the science moved on a long time ago. The prescription pad just never got the update. I'm Dr. Ava Carter, and on this channel, I take the research that's changed and explain it in plain language for people over 60, so you can walk into your next appointment already knowing more than a rushed 12-minute visit will ever give you time to learn. Before you decide this doesn't apply to you because your numbers look fine, understand something. That acceptable reading is the whole trap. It's the reason a pill can be quietly working against the rest of your body while everyone in the room keeps nodding at the cuff. By the end of this video, you'll know 3 things. Whether your medication is one the guidelines have quietly moved away from, the specific ways it can work against a body over 60, and the exact questions to bring to your next appointment so this finally gets a real look instead of getting renewed on autopilot for another 3 years. And honestly, this exact situation, a medication doing something to you that nobody's tracking, comes up constantly with my own patients, not just around blood pressure, but across the board. So I put everything I walk my patients through into one simple plan for living stronger and healthier after 60. It covers the 28 things that quietly shift as we age: blood pressure, blood sugar, memory, balance, and more. Thousands of people are already using it. The link is on your screen. Go take a look at dravacarter.com. Now back to that pill. Let me walk you through what a beta blocker is actually doing inside your body, because once that clicks, everything else in this video will make sense. Your heart is covered in tiny receptors called beta receptors. Adrenaline, the hormone your body releases when you climb a hill or hit a stressful moment, docks onto those receptors and tells your heart to beat faster and harder. A beta blocker sits on those same receptors and blocks adrenaline from reaching them. Your heart rate slows down. Each beat pushes with less force. Your blood pressure drops. That's the entire mechanism. Now here's where I want to be completely fair, because this part matters enormously. For certain hearts, that calming effect is exactly what's needed. If you've had a heart attack, if you're living with heart failure, if your heart has a dangerous rhythm problem, slowing and steadying that heart saves lives, full stop, and the evidence behind using a beta blocker in those situations is about as solid as evidence gets in medicine. I would prescribe one for those patients without a moment's hesitation. So please don't walk away from this thinking these are bad drugs. That is not what I'm telling you. The problem is who else ended up on them and why nobody ever took them back off. For decades, beta blockers were the default choice for plain ordinary high blood pressure. You might recognize yours by name. Metoprolol, sold as Lopressor or Toprol. Atenolol, sold as Tenormin. Propranolol, Bisoprolol. They were cheap, familiar, and doctors wrote them by the tens of millions every single year. Then the research caught up, and it wasn't kind. In the mid-2000s, one of the largest blood pressure trials ever conducted, the Ascot trial, followed more than 19,000 people with high blood pressure for years. Half were managed with a treatment plan built around a beta blocker. The other half were managed with a plan built around a calcium channel blocker, a drug called amlodipine that lowers pressure by relaxing the artery walls instead of slowing the heart down. The trial was actually stopped early because the gap between the two groups had already become too obvious to justify continuing it. The group not on the beta blocker had meaningfully fewer strokes, fewer cardiovascular events overall, fewer cardiac deaths, and a noticeably lower rate of new diabetes diagnoses. Hold on to that diabetes finding because I'm coming back to it. and it matters more than it sounds like it should. That evidence was strong enough that the UK's national guideline body NICE formally dropped beta blockers from the first choice list for uncomplicated high blood pressure, not banned. Still recommended for the heart conditions I mentioned earlier. But for straightforward high pressure with nothing else going on, they stopped being the preferred pick. And that position has held for close to 2 decades now. Here in the States, though, millions of people are still on one as their main blood pressure medication, usually because a doctor started it years ago. The number came down and nobody has revisited the decision since. There's no alarm that goes off in your medicine cabinet when a guideline quietly changes. The prescription just keeps renewing itself. So let's get specific. Here are the actual ways this can work against a body over 60. Pay attention and notice if any of these sound like the last couple of years of your life. The first is the one I hear about constantly, and it has a very particular shape to it. Remember what the drug does. It keeps your heart from speeding up when you ask it to. For a younger person sitting at a desk all day, that ceiling is basically invisible because they rarely push their heart hard enough to hit it. But you're not sitting at a desk all day. You want to walk to the mailbox, carry groceries in from the car, climb a flight of stairs without stopping halfway up. Every one of those tasks asks your heart to speed up, and the beta blocker is holding the reins. So you hit your limit sooner than you should. Your legs feel heavy before they have any right to. You're out of breath doing things that used to be effortless. This doesn't happen to everyone, but for a lot of people over 60, especially those with less reserve to begin with, it's very real. I had a patient I'll call Walter, and I want to be upfront that Walter represents a blend of several patients I've cared for over the years, not one identifiable person. He was 74, and he told me he'd quietly given up his morning walk around the block. His knees were fine. In his own words, he just felt like he was running on fumes by 10 in the morning. He'd been on Actionable for 4 years. His previous doctor had chalked the fatigue up to getting older. Nobody had thought to look at the pill bottle. And here's the part that stings a little. The single best natural tool you have for lowering blood pressure is movement. If the medication makes moving feel harder, you move less. And when you move less, your pressure tends to drift back up over time. So a pill meant to bring your number down can end up making the thing that lowers it naturally feel out of reach. If your walks got shorter around the same time you started a blood pressure medication, that timing is worth writing down and bringing up. The second issue is metabolic, and I want to be precise here because a lot of content online oversimplifies this badly. The older beta blockers, Actionable and Metoprolol, which are exactly the ones most seniors were started on years ago, nudge the body in the wrong direction on blood sugar and cholesterol. They can make your cells somewhat more resistant to insulin, the hormone responsible for clearing sugar out of your blood. They tend to push triglycerides up and HDL, the protective cholesterol, down quietly in the background while your blood pressure number looks perfectly fine on the surface. Large analyses following tens of thousands of patients on beta blockers have repeatedly found a meaningfully higher rate of new type 2 diabetes compared to patients on other blood pressure medications. That lines up exactly with the Ascot finding I mentioned earlier. Same pattern showing up study after study. Now here's the nuance almost nobody tells you, and it's the reason I don't want you jumping into blanket panic about your medicine cabinet. Not every beta blocker behaves this way. Newer ones like Carvedilol and Nebivolol are built differently. They relax blood vessels as well as slowing the heart, and they're much closer to neutral when it comes to blood sugar and cholesterol. So if you happen to already be on one of those, this particular concern mostly doesn't apply to you. This is really a story about the older workhorses, Actionable and Metoprolol, which just happen to be exactly what most people over 60 were started on decades ago. A quick word on weight, because you may have heard these drugs pack on the pounds. The honest number is much smaller than the scare stories suggest. On average, it's a few pounds, mostly in the first several months, and mostly with the older drugs specifically. It's a real effect, just not a dramatic one. But if you're already working to manage your blood sugar or your waistline, even a small push in the wrong direction from a medication that isn't outperforming its alternatives is worth a second look. The third issue isn't really a side effect so much as a blind spot, and it's honestly the one that concerns me most. A beta blocker often does bring your number down. Your cuff reads 126/76. Your doctor sees that, you see that, and everyone relaxes in the room. The number looks clean, but that number is only one window into your health, and it happens to be the one window this particular drug keeps looking good through. Underneath a perfectly acceptable reading, if you're on one of the older beta blockers, your insulin resistance may be slowly climbing, your cholesterol may be drifting, and your energy may be quietly draining away, and none of that shows up on the cuff. You can have a beautiful blood pressure reading and still be sliding backward in every other sense. There's one more worth mentioning, and I want to be careful here because it gets oversold online constantly. Like most blood pressure medications, beta blockers can leave you a little lightheaded standing up too fast, that swimming feeling when you rise from a chair. In an older body, that unsteadiness deserves to be taken seriously because a bad fall can start a spiral that's genuinely hard to recover from. I'll be honest that the evidence tying this specifically to beta blockers more than to other classes of blood pressure medication is genuinely mixed. But it's one more reason the newer classes are usually what we reach for first in seniors today. Before I show you what the research actually supports instead, which is the part you came here for, I need to stop and say something clearly because it could genuinely protect you. Do not stop a beta blocker on your own. Not by skipping doses, not by cutting a pill in half because a video told you to. Once your body has adjusted to one of these medications, pulling it away suddenly can cause a rebound. Your heart rate and blood pressure can spike hard and fast, and in a heart that isn't perfectly healthy, that can trigger chest pain, a dangerous rhythm, even a heart attack. Coming off a beta blocker has to be tapered slowly over several weeks under a doctor's supervision the whole way. What I'm giving you today is information and the right questions to ask, not a green light to start making changes on your own. With that firmly established, here's what the research favors for a senior whose only real issue is plain high blood pressures. The first option is that same calcium channel blocker from the Ascot trial, amlodipine. It lowers pressure by relaxing the muscle in your artery walls, opening the pipes rather than slowing the pump. It carried the winning side of that trial. It doesn't come with the same metabolic baggage as the older beta blockers, and it doesn't put a ceiling on how hard your heart can work when you need it to. The second group is a pair of closely related classes, ACE inhibitors and ARBs. These work on a hormone system that tightens blood vessels and causes your body to hold on to salt and water, and they gently turn that system down. Lisinopril and ramipril are ACE inhibitors. Losartan and olmesartan are ARBs. They tend to protect kidney function. They do well in people also managing diabetes, and they're easy on the metabolism. One quirk worth knowing, ACE inhibitors give a meaningful minority of people, roughly 1 in 10, a nagging dry cough. If that turns out to be you, an ARB does nearly the same job through nearly the same pathway without the cough. It's usually a simple switch. Now let me draw the line just as clearly in the other direction, because I don't want a single person walking away from a medication they genuinely need. If you're on a beta blocker because of a prior heart attack, heart failure, a rhythm problem like atrial fibrillation or angina, that's an entirely different situation, and the case for staying on it is strong. Newer research even shows the benefit after a heart attack is clearest specifically when the heart's pumping strength has been reduced. So it's worth knowing exactly why you're on yours in the first place. Everything I've laid out today is aimed at one specific person. The senior with a diagnosis of plain high blood pressure, nothing more, who was started on an older beta blocker years ago and never had that decision revisited. So here's exactly what to do with all of this. Not tonight, not in a panic. Calmly and in order, first find out exactly what you're taking. Go read the bottle. Is it a beta blocker? One of the names ending in olol. Metoprolol, atenolol, bisoprolol, propranolol, carvedilol, and is it there purely for blood pressure or for one of those heart conditions? If you can't say for certain why you're on it, that alone is worth a phone call. Second, write down 3 questions before your next appointment because the visit will be short and you'll forget them the moment you sit down. Question 1. Is my beta blocker here specifically for blood pressure? And does that still match current guidelines? Question 2. Have we checked my blood sugar and cholesterol recently, given what this drug can do to them? Question 3. Based on my full picture, would I be a reasonable candidate for switching to a calcium channel blocker or an ARB? Third, ask for a full medication review. If you've been on the same blood pressure pill for more than 2 or 3 years without anyone re-examining it, you are completely within your rights to ask for a fresh look. A great many people are still taking what was standard practice 2 decades ago, simply because nobody has reconsidered it since. Fourth, if you and your doctor do decide to make a change, ask specifically about the taper. A careful doctor will bring you off gradually over several weeks, keeping an eye on you the entire way. Fifth, start tracking now before your appointment. Keep it simple. Each morning, write down your blood pressure reading, your energy on a scale of 1 to 10, and if you check it, your fasting blood sugar. 3 or 4 weeks of your own numbers turns a vague "I've just been tired" into hard data your doctor can actually work with. That single sheet of paper can change the entire conversation. Walter, the patient running on fumes by mid-morning, eventually did come off Atenolol, tapered over about 2 months, and moved on to a different combination without it. I want to be honest about how that went because these stories get oversold constantly online. He didn't wake up feeling 20 years younger, but within a few months, his blood sugar had settled back into a healthier range. He'd lost a few pounds he hadn't been trying to lose, and he'd started walking around the block again. He told me he finally felt like himself for the first time in years. His blood pressure stayed exactly where it needed to be, if anything, a touch steadier than before. People assume stepping away from a blood pressure drug means losing control of the number. For the right person in the right circumstances, it simply doesn't. That's the whole point of this video. The medication you're on should fit the person you are right now, not the person you were the year it was first prescribed. Nothing here is me telling you to stop anything on your own. It's me telling you that you're allowed to ask whether your prescription has kept up with the evidence. Medicine moves forward. Sometimes the prescription pad just doesn't move with it. If this helped you look at your own medicine cabinet a little differently, do the small things that keep this channel going. Subscribe, leave a like, and tell me in the comments your age and the name of the blood pressure medication on your bottle right now. I read every one, and it genuinely shapes what I cover next. And if someone you love is on a blood pressure pill and dragging through their days, send them this video today. One honest conversation with a doctor, armed with the right questions, can change how the next 10 years feel. I'm Dr. Ava Carter. Take good care of yourself, and I'll see you in the next one.